Good evening. My name is Russell Ackaway, and you're watching Respect. It's a live TV talk show which accomplishes two things. It gives you the voice, and it helps young viewers who are watching help with the subject matter that's being discussed by the panelists. Tonight we have a very important subject, extremely important subject to talk about. The topic is teenage and young adult suicide. To speak to that, we have a very experienced physician. His name is Dr Saxe, MD. He's chair of the Department of Child and Adolescent Psychiatry, NYU Langone Medical Center, and also director of the NYU Child Study Center. Now that's quite a, I don't know why you took this job, Glenn. Dr Saxe, MD, joined NYU Langone Center in October 2010 as chair and clinical professor of Department of Child and Adolescent Psychiatry at NYU School of Medicine and director of the NYU Child Study Center. He's a physician, scientist with a focus on the psychiatric consequences of traumatic events on children. Dr. Saxe most recently served as the director of the Center for Refugee Trauma and Resilience at Children's Hospital Boston and the director of the Mental Health Informatics Laboratory and associate professor of psychiatry at Harvard Medical School. Previously, he was chief of the Department of Child and Adolescent Psychiatry at Boston University. Dr. Saxe and his team have developed Trauma Systems Therapy, TST, a community-based intervention for traumatized children, which is now used in programs related to medical trauma, refugee trauma, child welfare, substance abuse, and residential care across the United States. He received his training at Massachusetts. He received his medical degree from McMaster University in Hamilton, Canada. He completed his training at Massachusetts Mental Health Center, a fellowship in traumatic stress disorders at Massachusetts General Hospital, and a fellowship in adolescent psychiatry at Cambridge Hospital in Boston. Welcome.
Thank you, and thanks for inviting me.
Thanks, Glenn. Well, we know one another, so I can call you Glenn.
Of course.
So, you've been working in this field, and why don't you begin to tell the audience more about the work you've done?
Yeah, well, as you were saying, I'm a specialist in traumatic events in childhood and helping kids who've experienced bad events. I've also worked a lot with kids that develop self-destructive behavior, both related to trauma but also independent of traumatic experiences, and have seen the devastating effect that suicide has had on families and communities and that sort of thing.
Okay. So tell us about some of the studies that you've done.
Yeah. Well, regarding suicidal behavior, I began working with communities when I was living in Boston, where I was until recently, and we worked with a community in South Boston that had a high school suicide epidemic in the late 1990s, 98, 99, even into 2000, and it was a devastating epidemic where several kids, high school students, killed themselves, and several more made serious suicide attempts, all within a proximity of each other. And At the time, I was chief of child psychiatry at Boston Medical Center, and my team did a response to the schools and saw how terrible it was across the school, the communities, the families, the teachers, the kids. And so we developed programs to help those kids in South Boston.
Was there something going on that prompted the suicides in the environment and in the culture?
Well, it's hard to know exactly. There was this cluster of really bad events that happened, and several people have looked into how it happened and how it started. Several people point to the first couple of episodes were popular kids in the community, kids that other kids looked up to, kids who were prominent on the sports teams. And that began something, but it seemed to take a life of its own. South Boston is a community that for years has been in a lot of crisis. There's a lot of drugs in the communities.
You're talking about inner city?
In Boston,
downtown?
Yes. Yeah, in just the south of Boston.
Okay. How did the kids come to you?
Well, what happened was we ended up going to them, which I think is very important when you're dealing with high schools and kids in high schools. It's you want to be where children are. You want to understand who is at risk there. And so our response was to be very much in the school and try and help support the school to have a safety net that might identify kids early that were at risk and get them the help they needed as quickly as possible.
Did you make presentations to the students, or did you rely on guidance counselors and social workers and teachers?
Yeah.
Feedback?
Well, it's a very good question and really important for the project that developed. When we began the project, and this was early 2000s, we thought we would work with the school and parents as what are called gatekeepers, people who would identify a suicide prevention team when a kid was at risk. But what happened early on is we began asking kids who they would go to if they were in trouble. And we conducted focus groups with several groups of kids, and the results were pretty resounding that the last person a teenager would go to in the high school, in these high schools anyway, was a teacher, and the second to last person was a parent. We developed the program all around teachers and parents, so we were in some trouble because we conceived of it all wrong. And then we began to think and ask kids who they go to, and of course the answer is relatively obvious if you think of it. They go to another teen in the school.
A peer?
Yeah. And so what we began to...
Excuse me, were these males and females?
Yep.
Mixed?
Yep.
What's the age range?
These were high school kids, so through the years of high school.
No middle school?
No, only high school. And we began then to work with peer leadership groups, identifying kids who became the go-to kids in these schools. And over the years that we were operating, they would find out kids who are in trouble. We would work very, very closely with them, not making sure that our peer leadership group was not alone with managing big-time problems, but that there was a mental health team that worked closely with them. And what we found that this is a far, far more effective way of practicing.
What was the who was part of the mental health team?
Yeah, it was. We had.
And were they trained?
Yeah. So we had. This was a mental health team that I managed. They were social workers and psychologists who were very aware of issues related to teen suicide and risk. We were very well connected to emergency services in Boston. And so it was a team that was very good at working with peer leaders and training them and helping them to really be leaders in the school, to have a certain profile in the school, to be looked at by other kids and teachers and guidance counselors as leaders, and that really, really helped.
I imagine it might be quite threatening for a professional to work with a kid who is such high risk. How was that dealt with? I mean, did that come out, and was there like role playing or anything like that?
Are you saying from the peer leaders feeling intimidated or threatened?
No, the professional.
Yeah. Well, we selected pretty well-trained people.
Okay.
Who really understood how to appraise suicide risk, to help manage the risk, to help get people to the right places, and we provided them a lot of support as well.
Okay. So how did that work? What were some of your findings?
Well, what we found is that we were able to identify children in a pretty efficient way, in a way that the school had not been able to achieve before when there wasn't a safety net like this in the school. We ended up developing a brief intervention that was part of the program, and found that we were able to diminish risk. And it became something that was a very valuable part of the school and the community. We worked very hard to build that, and it involved a lot of community building.
We have a caller. Hello?
My name's Jamie.
Hello, you have a question?
Yes, I was wondering, it seems like there were a lot of support put in place, but what was the impact? Did any of this help these students?
Yeah, what we found is, well, the first thing is that before this program was in the schools, kids really didn't have places to go. And there wasn't a safety net to identify kids. There wasn't a ready way of providing good care in the schools. The other thing is there was no culture within the school for kind of safety, a culture of kind of people caring for each other around risks like this. And what happened is that the peer leaders in the school really helped drive the culture. It's one thing for teachers to say that we need to be a certain way, but when you had kids in the school who were seen as leaders, it really helped change things. The kids who were the peer leaders used to wear T-shirts to identify themselves, and they had a motto that was called "Never Worry Alone." And that was really important. It was a strong message to the student body that people are there for you, that you can seek people out. Suicide is usually a stigmatized thing, and people feel ashamed. But when you have leaders within the school that are going to be public about it and are known and wear T-shirts that say such things as "Don't worry alone," it really kind of sets the stage for the right things to happen.
Sounds wonderful. So there wasn't any kind of screening, I mean, with paper and pencil tests, anything like that, testing?
Well, when
Psychiatric?
yeah, when we had several levels of risk,
Yeah.
and when a child would be identified to the program, we would do assessments. And within that assessment, we determined the level of risk based on known risk factors for suicidal behavior. And so we did assessments in that way.
And what were those risk factors? Could you describe them?
Yeah, I mean, issues like substance abuse, histories of trauma, depression and the degree of depression, within symptoms of depression, hopelessness, feelings of loneliness, alienation were very important. And then the things that you need to be asking about is what really are the ideas that someone has about harming themselves? How real do those ideas seem?
You mean suicidal ideation versus actual suicide?
Yeah, I mean, how specific are the ideas? How clear is a plan to carry that out? Do people have means at their disposal to harm themselves? So these are parts of the risk that were assessed.
Okay, we have a caller.
Hello?
We have a question.
Yes. I wanted to know if
Hello?
that I have a child. Hello, can you hear me? Hello? If I have a child that's
Hello?
suicidal, can you hear me? Hello? Hello? If I have a child that's suicidal.
Hello?
Hello? Okay.
They might have dropped the call.
Okay.
Could be a crank.
Hello?
Hello?
Yes, I have a question. If I have a child that's suicidal, as a parent, and what can I do? Because you said that the parents are always the last to be told. So, is there anything that a parent can do when we see these signs?
Yes, I think thank you for the question. That's really important. And even though within our program we got information that teens would prefer to seek out their friends, that's not universally true, of course, but we got that as the common response. I think parents have a vital role to play, and the degree to which you're attuned to your child's needs, that you've developed a level of communication with them that is safe enough for them to seek you out and let you know what's going on. And if you're in a situation where your child does confide in you that they are having thoughts of harming themselves, then they're trusting you enough to help them get to proper care. And so then if you can help them get a psychiatric evaluation to help sort out the risk, that would be a really important thing.
Okay. I mean, I don't want the child to think that I'm gonna lock them up or anything like that. I mean, but they might need that for a short time.
Usually people don't need that. Obviously, you can't make promises that you would never. But I think that way before then is that if you have a child that is really suffering in that way, part of it is really the trusting relationship that develops, and you want to help them get to the right place where they could be treated and helped. And so I think it's really very important, but part of it is dependent on what you've established way before the child tells you about suicide, about open communication and a trusting relationship.
But how can I build that relationship when I feel like it's so far gone now, and I feel like the child is too far away for me to reach them? I want to establish this relationship, but if I feel like they're not going to want to listen to me, they listen to their peers, but they won't listen to me.
Well, if I can ask you, are you in a situation where you have a child that has told you they're suicidal, or you believe they're suicidal for another reason?
They're just distant. I don't know. Maybe the drugs. I can't make these assumptions. It's just they're so far. They're not the child that I knew.
Yeah. So sadly, not an uncommon problem. And there's no easy answers, of course. You have a child who presumably at one point, was closer, and now for a variety of reasons they seem distant. You mentioned drugs.
That's what the kids do. They listen to the rap music. There seems to be stuff like that, going on like that. I just assume. The culture.
Well, have you what happens when you sit down with them and begin to ask what's going on?
They're always kind of like, out, I'll be back later, I'll be back later. Talking on the phone, texting their friends, always out, always out.
I guess all I'd say is that there's no easy answers here. I hope I'm not making it seem like there is. And, no magic, but to the degree that you can express interest, be really attuned to them, try and be involved to the degree you can in their interests. If someone tells you something that is really concerning, then you may need to seek out consultation yourself from a mental health professional to guide you in the specific circumstances, which I obviously don't have enough information to guide you in.
I have.
Also, let my child know that
I'm going to have
I'm
to
there for them.
just put her to rest. I have a question.
Yeah.
I guess it must be very difficult for parents who are abusing, dependent on drugs, alcohol. The kids may have picked up prescription. Some of them are ill themselves, could be bipolar. What work was done with the parents to help support your program?
Yeah. It's a very important question because parents can have a very important role.
Extremely.
And one of the things that happens is that if parents are really out of the picture in ways you've described, either through substance abuse or their own mental illness, it sets the stage for big problems. And it's one of the things that we had termed a cycle of desperation. So you have a kid that's feeling alone for lots of reasons and in distress, and they emit signals to parents, and the parent, for a variety of reasons, doesn't pick up on it, having their own problems, and is not attuned to step forward to help. Then the child feels more alone, and then emits more signals, and becomes more and more desperate, and may seek out a peer group, maybe a peer group that is involved in antisocial behavior, drugs, crime. It's a group that is at least with them. I'm not saying that's the usual situation. You had mentioned the type of problems that develop when parents have their own serious problems, and it's why I think that when you begin to work with a child, a teen, who's at significant risk, you can't really work with the child alone. You really need to bring in supports and really try and work with parents to the degree you can.
Did the just slipped my mind. Was there more success with families that were less dysfunctional, educated? What did it have to do with those variables?
Yeah. I mean, part of it is the environmental and family risk factors are always there, and it means that it's less complex to help a child who has suicidal feelings when the family is intact and engaged and helping. And if that's not there, then what's very important is to look, are there extended family? Are there grandparents, aunts, uncles that may be brought in to help?
Uncle, yeah.
you try and figure out who can step in and help. And you try and, as a therapist, as a clinician, try and get the family, the parent, if they really need their own help, to make sure they get it. But it's not easy, of course.
You make home visits?
One of the things we did, both within that program and others, is to bring in home-based care within the program. I think that's very important.
It is.
Yeah.
It is. The question slipped my mind again.
But your questions about the family are very important, and it's very hard to help a kid without really understanding the social context in which the problem.
I know what it is now. The healing elements were the professionals and the peers.
Yep.
And they became the good enough parent in that.
Well, I think part of it is, I understand the way I think about suicidal behavior is that there's something about feeling desperate and alone. Feeling
Indifferent.
and feeling like there aren't the people there to help you. You're alone with really difficult feelings. And so if you create environments in which people are there to support, it helps with exactly that problem.
I agree. I'll share with the audience, early in my career, I had a methadone addict, suicide. Of course, he was under psychiatric supervision when he began to talk about it. He told me he had a stash of methadone and that he could just as easily take it. He was a very famous hair designer in the salons. So he became, as they usually do, became a methadone counselor, and is still in that element. So there were two incidents that broke him. He found out his wife was having an affair, and his mother was Meshuggah, and he went to see her in the hospital, and she called him Moses. So those two triggers, put him over the edge. And he didn't show up for the one session. I called the office, and they said I was a very young therapist, and my supervisor was very supportive. I didn't know anything.
Yeah, but it's awful all around, for sure, with something like that.
And I had another patient who was bipolar, who I helped get through college. I told her to get a tutor, some help. They don't know how to reach out.